We do provide the platform of the Pennsylvania Cancer Coalition as the home for these meetings. They are uploaded and available there. So thank you, Monica. I see that the recording now officially has started. Great. So it is again there for future reference. So I am here to welcome you along with my fellow co-chair Lynn to today's meeting. Lynn, anything you would like to add before we move to the next slide?
Not at this time. Thank you.
Thank you. All right, well, we're going to get right to it with our first presenter, Dr. Stephen Ellis, who is a part of our Pennsylvania Department of Health Bureau of Epidemiology, who's going to take us through some really good content on COVID-19 and cancer patients. So Dr. Ellis, if I could turn it over to you, I think you're driving your own slides for today's presentation.
Great, thank you, Kate. Yes, I'm right now trying to share my screen and load my slides so people can see the presentation. Let me know when you can see them, please.
We can see your screen, Dr. Ailes. Now we're just waiting for you to navigate to the presentation.
All right, thank you.
There we go.
We getting there?
There we go, and just start the slideshow.
Okay, can you see everyone can see the slides okay?
We can see the slides. We just need you to go into the presenter view when you click slideshow.
Okay, got it. All right, well, I want to thank Rebecca Kishba for inviting me to participate here in your quarterly meeting, and I'm happy to present some of the work we've been doing at the Pennsylvania Department of Health Bureau of Epidemiology related to COVID-19 antibody testing in a variety of different populations, but our project is really focused into the immune compromised and people vulnerable for severe disease, and so I'm happy to present some of the work that we have been doing. Okay, and so can you see the second slide? It says antibody test parameters.
No, we can't, Dr. Ailes. They're all on the side. We need you to go down to that bottom right and just next to the bar with the line where you size the slides, right next to that will start your slideshow.
Okay, yeah.
So it's there, but we just don't see it in slideshow format.
Got it.
Come down to the right. There you go. Go back to where you just were.
All right, thank you. So I have two screens on my computer station, and
yes, you will, because Teams does one for the background and then one for where you're presenting.
All right, so, and now can you see the antibody test parameter slide?
Yes.
Okay, so just to start off with the resources that we have at the Pennsylvania Department of Health, we're stuck with what we've got. And I'm not complaining about it at all, but it's just important to know that, when we do serology work, the antibody test is what it is, and we have to understand what it does, what it doesn't do. And so I present this slide first just to show in all the populations we've been doing antibody testing throughout the last year, this is the test. And it's performed by the Pennsylvania Department of Health Bureau of Laboratories. And so great colleagues have really been doing a nice job with us to coordinate all of the testing that we've been doing. The test is the Euroimmune anti-SARS-CoV-2 ELISA, IgG to the spike protein. That's important. So if it's positive, it doesn't distinguish between previous infection or vaccination. So a positive test result with this assay, you interpret it as either fully vaccinated or previous infection. We can't tell the difference. But if it's in somebody who's unvaccinated, then we interpret the positive test result as being due to previous infection. Okay, and then the sensitivities and specificities are here. I'm showing them because the sensitivity is not perfect, meaning that the test sometimes will test negative, even though antibodies might be present in the sample. And that happened 3 of 30 times in the test package insert of this particular test. So I say that because I have this sense of caution in the back of my head when I'm dealing with a negative test result in somebody I think should test positive. And then it's qualitative only. We don't get antibody levels. It's either positive or negative. And sometimes our lab will result out the test as borderline. Okay, can you see the next slide? COVID serology long-term care facilities?
Yes.
Thank you. All right, so how we got into working with cancer patients. So we initially started this work back in December of last year, and we were heavily focused on long-term care facilities, nursing home residents and staff, where a lot of big outbreaks had been happening and a lot of severe disease and death were occurring. So we did a job up in Lackawanna County on February 26th, and of staff we tested, there were 81 of them. We had 3 people that were fully vaccinated test negative. And so here I could say, well, that could be that false negative result. But we're very careful with our samples and our lab is excellent. And so I did go back to these 3 people and just kind of ask a little history about them, as I described them, why their result was negative, what that meant. All 3 told me they had an active cancer diagnosis going on. So that was an explanation as to why they might have an immune suppressive condition and could have tested negative, not a false negative. So this led to a new objective for us back at the end of February, and that was really to start working with immune compromised people to see what are their levels after vaccination and are they seroconverting. And so just to dig a little bit around the subject of cancer patients, suddenly I'm getting an echo. Okay. There were a couple of articles and conversations I had with a colleague out at the University of Pittsburgh Medical Center. We found that were some publications around people not seroconverting for antibodies for COVID-19 that were cancer patients, particularly patients that had a hematological malignancy disease like chronic lymphocytic leukemia and other conditions like multiple myeloma. So this was out there with small cohorts of these patients to show that 46% seroconverted, 48% seroconverted. But a lot of these populations were not included in the clinical trials done by either Moderna or Pfizer, which were the 2 vaccines we were concerned about back in February. Okay, so we had to get into working with some oncology practices to see, can we actually work with them to test their patients? Not an easy thing to do. And so we were able to leverage a relationship we had with one particular practice up in Lackawanna County because they had recently been dealing with cases of COVID among their staff, and our infection control team was working with them closely, and they had a good working relationship. And so they helped us make this invitation to that practice. And then I sort of went around and tried to ask other practices if they'd be interested in letting us come and test their staff and patients. And so 2 accepted, this one in Lackawanna County, and then we were successful with another big practice in Lancaster County. The big concern, though, that we heard from the practices were, us being on site for multiple days collecting blood cannot interfere with their practice. So we can't slow patients down from being seen by their providers when they're coming in for their appointments. And so that was something we heard loud and clear. All right, so the first collection we did was in the beginning of May. We were up in the Lackawanna County practice for an entire week, and we offered the testing. The practice sent invitation letters to every patient that had an already scheduled appointment that week to come in for their appointment and then get the blood draw before they went and saw their provider. And what was beautiful about this particular practice is almost every patient has a blood draw done at the practice before they see their provider. And so we were able to just add the antibody blood tube with the phlebotomist that were already drawing their blood. So it didn't result in a second needle stick, and it just kind of smoothly went into their daily practice. All right, we did have to get consent from everybody to agree to allow us to do the blood draw, use it for antibody testing, and then we issued a questionnaire about COVID attitudes to everybody as well. So we had some paperwork to do on the front end with them as well. Results were given to patients over secure email, and letters went to their homes telling them that they tested positive or negative. And then I had office hours twice a week in the afternoons and gave them my work phone number so that they could call me if they wanted to discuss their results. And so I had a lot of interactions with different patients happily to explain what their results mean, listen to what their conditions were, and then to offer them some counsel on how to avoid contracting COVID in the future. But for this job, we did 220 total specimens were collected, 154 from patients and 66 from staff. Okay, so looking at some of the patient results from that first draw, This was a hematology and oncology practice. So many patients were strictly hematology patients. They didn't have an active cancer diagnosis. So that broke down to 64 and 90 oncology patients. But just looking at the data roughly, we broke it down by fully vaccinated status, partially vaccinated status, meaning that they weren't 2 weeks past their second dose of a 2-dose series, or 2 weeks past a Janssen dose that they may have gotten. And then unvaxxed never had any vaccine. And so just looking at the results here for the 154 total patients, 88.3% tested positive. So many had antibodies for whatever reason, either they were due to vaccine or previous infection or both reasons. But we focus here on the patients that were fully vaccinated that didn't test positive. And so our lab results out this borderline result rarely, but it is, I guess it is what it sounds like. It is somebody that might be in the middle of not testing positive and negative. And I won't go into the details of how the lab explained what a borderline result is, but I could if you'd like me to. But that total cohort was 11 of 134 fully vaccinated patients. 8.2% did not seroconvert. Okay, so now just taking the hematology patients aside and looking at the 90 cancer patients, what did we see among them? And so breaking that down, 36.4% of fully vaccinated hematological malignancy patients. So these are people with a blood cancer, multiple myeloma, leukemia, lymphoma, myelodysplastic syndrome we added into here as well. We saw that many more of the negatives or borderlines fell into this category, so 36.4%, compared to 2.9% of the solid cancer patients. So everybody else with a solid cancer like breast cancer, lung cancer, colon cancer, melanoma, et cetera, very few of them that were fully vaccinated tested negative or borderline. So a big differential between the blood cancers and the solid cancer patients. Among the 8 heme malignancy patients who tested negative or borderline, we had 3 with leukemia, 2 with lymphoma, and 3 with myeloma. All right, and then the other thing we do, we issue questionnaires to everyone we do our serology work in, because we like to kind of hear how well they protected themselves and other attitudes around vaccine and so forth. And so I just shared this slide where we look at the hematology patients, the oncology heme malignancy patients, and then the oncology patients, solid cancer or not heme malignancy patients as 3 groups. And how did they answer these questions? And so the only thing I'd say, if you look at the dark blue bar, that's the heme malignancy patients, and they seem to protect themselves a little bit better. And so less had a previous COVID diagnosis that they knew of, fewer had been identified as a COVID contact and told to quarantine, fewer left home at the most frequent category of more than 4 times per week, and then more maintained social distancing when they were out of the home compared to hematology patients and solid cancer patients. Okay, and so moving on, we were successful and have a great relationship now with this practice up in Lackawanna County. And so we had asked to come back a second time, and they agreed. And so we offered the test again to all patients with a scheduled appointment the week of August 2nd to 6th, so 3 months later. And we also issued an invitation to all the 154 patients we did in May to come back in and get another test done if they wanted to. And so that recruitment resulted in a total of 327 total samples that we collected. So it was a big increase from the May of 220, 49% increase. 55 staff members and 272 patients this go around. And of the total cohort here of 327, there was 125 people we tested in May came back for a second test. So 52 staff and 73 patients we now had a second blood collection sample from. Okay, and so looking at the results from the second draw in August, we had a total of 272 patients here, and of them, 86% of these patients tested positive. That compares to 88% in May, so a little bit less, but probably not statistically significant, kind of in the same ballpark where 86% now tested positive. And this may be due to people that are unvaccinated. There are still some people that are unvaccinated. Here we have 19 or 7% almost in the entire cohort of these patients are unvaccinated. And then among the people that tested negative or borderline, we now had 24 in the new cohort of 9.8%, and that compares to 8.2% that we detected in May among all these patients. All right, so here we are now. If we combine the two sets of patient data that we collected in May and August, this is what it looks like. And it just sort of grows our numbers to see the relationships a little bit better and to add to some statistical confidence in what we're finding. And so the total, the negative or borderline positivity, the rate for people who tested borderline or negative among the hematology patients is 5%, similar with the oncology solid cancer patients of 4.6%. So that's kind of the same. And it's quite a bit less than the general public or the staff that we test, where we typically see 98, 99%, even 100% of fully vaccinated, otherwise healthy adults do test positive for antibodies. So a little bit lower than the general population here, these two estimates. But then the heme malignancy patients, again, are showing that consistent finding of somewhere in that 30% range that we've been seeing. Okay, and then the total population of all the patients was 9.7%. All right, and then we looked at the brand of vaccine that patients received and how did this relate to their antibody positivity or negativity. And so this is among all the fully vaccinated patients from both collections in May and August, a total of 308 here. And here we see that the breakdown of negative and borderline is striking across the different products. So for the Johnson & Johnson product, which was the one dose that people received, 45.5% of these people did not test positive. They tested negative or borderline, compared to 11.6% for Pfizer and 6.9% for Moderna. And this is completely consistent with what recent publications that are coming out and findings that are comparing these three vaccines. So I think the big takeaway now that we have this recommendation for immunocompromised people to get an additional dose is certainly for people with the Johnson & Johnson vaccine that fall into this category. It's indicated to get another dose of vaccine. Okay, and then here looking at the heme malignancy patients more closely, now we have a total of 55. So we grew this cohort from 24 to 55, and breaking that down by the type of malignancy that they had, the type of blood cancer, we really see that it's kind of consistent. You know, we hit numbers in each of these categories of myeloma, lymphoma, and leukemia, and we did add a myelodysplastic syndrome patient. And then there is this other category of other what seem like blood cancers that affect the immune system. And so we kind of have them sitting here too. We couldn't classify them based on the data we had of patient diagnoses into one of these other categories. So anyway, the percentages of negatives and borderline are somewhat consistent with, each of them contributing semi-equally to the overall heme malignancy rates of negativity and borderline testing. All right, and then just to conclude, we can compare what happened with people we tested in May and the cohort we tested in August. And so for these people that we have two samples on, what were the differences? This includes 52 staff and 73 patients. So among the staff, 52, these are otherwise healthy people, adults working in an oncology practice. 51 were positive during the first draw, and they remained positive during the second draw. One was negative during the first draw, positive during the second draw. And this individual was partially vaccinated when we drew their blood in May, and then they were fully vaccinated when we came around in August. Completely consistent information here. This is what we would expect to find in an otherwise healthy population. But for the patients, there were 73 total. 69 of the 73 stayed the same, where 65 of them were positive in May, they were positive in August. 4 were negative in May and negative in August. So we had a big percentage, almost 95%, stayed the same. but 4 changed their status, so 5.5%. 2 went from negative to positive, 1 went from positive to negative, and 1 went from borderline to negative. And so we continue to do this work because we're interested in people seroreverting, going from a positive status to a negative status. And that really only happened here for 2 people, I would say, among this cohort of 73. 2 negatives to positives, that's good news. Maybe they were vaccinated, they had other reasons. And I do have that detail, but that's what I think happened with those folks. And so just to point out, we know now that there is a 3rd dose, an additional dose recommended for people with immune compromise by CDC, and more recently, the additional dose that's been recommended for more seniors and people with chronic conditions. But just to add to where we're going with this and additional work that we've done that I don't have data to share yet is last week we were at a very busy oncology practice in Lancaster County doing the same thing. And so we collected 406 samples over the 5 days and 201 patients. And what I'll say is this was not a hematology practice at all. And so almost all of these patients are oncology patients. And a lot of them were sicker, in my observation, receiving infusion therapy during their appointments. And so I think we'll see more more people with a hematological malignancy falling into that category, and then curious to see what the results are going to show with respect to being antibody positive or not. And then I will say that we captured 3rd dose or additional dose in 40 of these 201 patients. So 20% had already gotten an additional dose of vaccine. So we're going to look closely now at the impact of 3rd dose. All right, and so just a couple of conclusions. Cancer patients are at high risk for severe disease from COVID-19. This we know, which is why the Department of Health has prioritized them for ongoing interactions and work to make sure that we're working with them to inform them and relate to them on the subject of keeping disease free. And then repeated small studies showing consistent poor antibody response following complete vaccination, especially among this hematological malignancy group, suggesting ongoing susceptibility to infection. Okay, so considerations that are out there is the value of antibody testing for cancer patients. I mean, it isn't really recommended by CDC to do this and to assess in an immune compromised population whether or not they seroconverted. And there's other nuances about the antibody test too that I didn't go into. You know, this does not test neutralizing antibody, so actual new antibody function. It just detects the presence. And it doesn't do anything about cell-mediated immunity. So it's not a full immune status picture, our test that we use. So that's important. But is there value in doing antibody testing for cancer patients? And I think if you ask a cancer patient, they're very interested and they do want the information. And, you know, I know that some providers use it in making some decisions. But right now, the decision is really if they tolerated vaccine previously, they should absolutely get an additional dose. But maintaining social distancing, mask wearing while they're antibody negative, I think that makes a lot of sense. People ask me if they should travel, and I counsel them on what the risks are of traveling to certain destinations, being on an airplane, driving, etc. And then close contacts absolutely should be vaccinated. Anyone that they live with should have received full vaccination so that they can't, so they're much less likely to expose the individual with cancer to the virus. And then repeat vaccination, this idea of timing it with chemotherapy. I mean, we didn't really capture medications, chemotherapeutic medications that patients are on, and the timing of vaccination and how that might have impacted their immune response if they're undergoing rounds of chemotherapy. And that's when they got vaccinated. It makes some sense that they didn't have a good reaction to vaccine at that time. So is timing vaccine in the future when they're in this recovery period between intervals of receiving chemotherapy? I think that makes a lot of sense. And then do you consider antibody retesting? And then this last bullet, I think, is a big problem. And so back in the winter and early spring, oncology practices, many were not vaccine providers. And the issues here, they wanted to be, but the issues that I've heard were that the ultra cold chain storage of the Pfizer product was prohibitive. And the logistics of actually managing a precious resource when it was brand new, some of these practices just couldn't do. And so they couldn't time vaccine to their patients with treatment and rather they really told their patients to just get vaccine as soon as you can. And I think this really has to be looked at, from a state preparedness standpoint on working more closely with oncology practices, but also pharmaceutical companies, future pandemic vaccines or this whatever vaccines might be indicated for populations like this really need to be made in a way that the logistics are much easier so that practices like this can actually have product and provide it to their patients directly. And then lastly, it's a touchy situation that, I worry that could happen. I haven't really heard that this is happening, but do patients have rights here with respect to who provides care for them? Because I have encountered many, not a lot, thankfully, but there are staff who work in oncology practices that are unvaccinated. And I think that if you're a cancer patient or you're a family member of a cancer patient, do you have the right to ask any provider that comes in contact with you if they're fully vaccinated? And if they aren't, can you refuse their care and demand that you receive care only from people that are fully vaccinated? My personal view is absolutely. But I don't really hear that this is happening a lot with real patients in real practices. But I know that the oncology practices I've been working with are concerned about this. And then what are the implications here for this idea related to other diseases like influenza every year? Okay, so that's all the content I prepared to discuss with you today. And then I leave this slide up, which is contact. If you'd like to email me, that's fine. I welcome your comments. But I'd love to hear some thoughts or questions from any of you about some of the information I just shared.
Thank you, Dr. Ailes. We do have a question in the chat and a hand raised. So I'll start with the question in the chat, which is, how long is a cancer patient considered immune compromised after having 2 cancers, the most recent in the last 18 months?
Yeah, that's a good question. And I'm not an oncologist, so I don't think I'm really, I'm not in a position to really answer how you classify somebody with cancer on whether or not they're immune compromised. I think it's really a combination of the type of cancer that they have that may directly affect the immune system, like these heme malignancies. Any cancer where the bone marrow is being consumed by cancerous, white cells or platelets or whatever, that interferes with normal immune function. And so those are conditions that I would classify as immune compromised, but also treatments that patients get. And then other diseases, transplant recipients, bone marrow recipients, people living with HIV that don't have their HIV controlled. Those are all classifications of populations that have immune compromise.
Thank you. And then we have a hand raised. Nathaniel, if you want to come off of mute and ask your question.
Sure, doctor. With the antibody test, are you able to distinguish any kind of different response from one variant to another? Since I think when you did this, the Delta variant was becoming the predominating variant in the U.S.
Yeah, that's an interesting question, and you're right. When we started this work with nursing homes and back in the winter and spring, Delta was not predominant in any of our populations, but clearly was now that we're here in the summer and entering the fall. So the spike protein antibody test that we use works with Delta virus as well. So if a person has infection with the Delta variant, the antibodies that they produce from that Delta variant would be detectable by this assay. And so the vaccine is the vaccine, so that the variant strains don't, the vaccines that people have gotten are the same, and so that doesn't matter with respect to predominance of the epidemic when we use this test.
Thank you. We have another question in the chat. How can patients obtain information about the vaccine status of the care team? Are there HIPAA concerns?
Yeah, that's a tough one. I mean, it's, if you think about public health law, what's out there is there's always language around protection of somebody from disease and even death. And these laws that go back in Pennsylvania and in the city of Philadelphia, where I practiced for years, that's kind of the idea behind how these laws are written and what gives public health authorities the rights to identify protected health information about vaccine status, even without patient authorization. We can do it as a public health authority, but it's sticky, and I don't quite know how to interpret the law with respect to an individual wanting to know that information from a provider. I don't really know what the legal ground is here, but I think there's a moral ground here for patients to understand when they're out of their home in an environment where there's a virus that could be deadly for them is circulating at high rates. I think they absolutely have a right when they're getting a critical appointment, their medical care, their treatment, to ensure that they are um, assessing what the risk to them is for that virus.
Thank you. And we have not a question, but a comment. I'll read that. So excellent presentation. This is from Lynn. Excellent presentation. I just spoke to a group of cancer survivors last evening and their care team as we discussed much of this information, but not in the depth of detail, data that you provided. So really just a nice comment there. And thank you, Dr. Ailes, for this presentation. I'll do a list call out for any questions that might still be out there from our participants.
Hi, this is Gene Langridge. Can you hear me?
Yes.
Yeah, good. So thank you. Very nice presentation. Glad to see the Pennsylvania Department of Health doing this. Do you have any information on incidence for these patients? And are you following this cohort over a period of time for incidence as well?
Yeah, you mean incidence of COVID-19?
Correct.
Yeah, unfortunately, the answer is no. And the reason that is because there are so many cases. You know, we're up to 1.3, going on 1.4 million cases. And unfortunately, to know other comorbidities, when we get a case report, it's a laboratory report of a positive, and we'll get minimal information about that person. You know, their date of birth, so we know their age, and their address, so we know, their county and their jurisdiction, but very little else. And so it takes an investigative team to go back and try to find more information about those individuals with respect to other comorbidities. And so there is some, we focus on long-term care facilities, those populations, congregate settings, and severe disease and hospitalizations, and deaths. And so to the extent that we can get information from the tens of thousands, even hundreds of thousands of cases that fall into those categories, it's challenging. And so I haven't really seen, coming from our own massive surveillance database, oncology diagnoses among the cases that we've seen.
Yeah, I was referring to your actual individuals that are in the cohort.
Oh, that's different. And yes,
Yeah.
we are able to, because that's a name-based cohort, we are able to go back and look and see if we have a known report from them. Yes, so we have done that. And most of them, I don't have the data in front of me to tell you how many actually have been previous cases. It's small, it's strikingly small. And I think it really has to do with their alertness to being concerned about catching it, and typically compared to other populations, they practice social distancing and prevention a lot better than other groups. So in contrast, we did a big serology project with university students, and we did 800 students at 4 big universities. And I can tell you, university students, that questionnaire slide I showed you about social distancing and mask wearing and leaving their home, they're the worst. So the incidence rate is quite low. We are able to go back and confirm that people were in fact cases to explain a positive result if they're unvaccinated. But this cohort is hardly unvaccinated.
Thank you.
You're welcome.
And thank you, Dr. Ailes, and I appreciate you putting your contact information right there in the slide. And so if there continues to be questions from the coalition, we'll encourage you to do that, direct reach out, as I know that there are still questions that are kind of coming in through the chat. So Dr. Ailes, if you could even look to that, if I could just request if you could kind of continue to maybe answer those questions as they come in and as we kind of move through the rest of our agenda today.
Okay. All right.
Perfect. Thank you again.
All right, thank you for having me.
Of course. And so Monica, if you could pull the slides back up, I think, Lynn, you're next up onto our presentation on our agenda.
All righty, I'm waiting to see the slides. Okay, I would like at this point in time, whoops, you were there, Monica. Next slide. I would like at this point in time for everybody, I know we're all virtual, but I think some of you can see where you can clap hands. If not, you can put little messages in the chat. I would like to thank Kate for her years of service in co-chairing the PCC. I know I personally am going to miss her tremendously. She's a delight to work with, very easy to work with, and really has been a lot of IT support over the last year, year and a half. Kate, this certificate up here is already signed, and I'm in the process of getting it framed, and then I will mail it to you as a token of our appreciation for everything you have done for the Pennsylvania Cancer Coalition. And I know you're not leaving us. You're going to continue to be a part of us. And I'm grateful for that. And I'm sure you'll remain very, very active. So once again, thank you for all you've done.
And thank you, Lynn, and to thank you to everyone. This has certainly been a joy to be in this role, Lynn, working with you. Mark, I know if you're on too, you know, I've had the real pleasure of having tremendous co-chairs and really just to be able to work in this space with all of you. You're doing such important work and really bringing so much to the patients across our state. Regardless of where they are in this cancer continuum. We are fighting a good fight. And as Lynn mentioned, I will continue to be a part of this coalition, look forward to that and kind of playing some different parts and really look forward to that. So really huge thank you. And yeah, just that, a big smile on my face. I'm gonna come on to video. Thank you.
Thank you. Okay, next slide, please. That being said, I would like to welcome Casey Monroe, who has a master's in social work, as the new incoming co-chair to the PCC. And many of you, I put a picture up there because this is virtual. So Casey, please, I hope you don't mind that I did put the picture. I wanted to make sure everyone knew who you were by seeing you. Casey currently is with Adagio Health. She's the Senior Director for Health Promotion and Disease Prevention. And I listed a few of her other prior roles so that you can see she brings with us, or to us, a lot of experience and a lot of things that I'm sure will benefit as we move forward in the next year with the PCC. So we want to welcome Casey, and I'm glad to have her as my co-chair. Any comments, Casey?
Thank you, Lynn. Thank you for this opportunity, everyone. And looking forward to hopefully filling some big shoes that Kate has left for me.
Okay, I think that ends what I need to do, and we can move on to the next portion of the meeting.
Okay.
Yes, this is you. Yes.
All right. So again, I want to thank Kate for all of her amazing work as the PCC co-chair. We really do appreciate your leadership and commitment to the coalition. So thank you again. Also, congratulations to Casey. We're really looking forward to working with you in this capacity for the next 3 years. I also wanted to mention one more leadership change. As you know, Sharon Sowers retired in July. And I'm pleased to announce that Brenda Anastasio will be the new Comprehensive Cancer Control Program Manager. She starts on Monday, September 27th. Many of you already know her from all of her work around HPV, lung, the Data Advisory Committee, and the skin cancer initiatives. And so we are thrilled to have her in this new position. Okay, so my part of this is that as a result of the survey that many of you members completed in June, one of the areas identified as a need to address was around understanding the role and responsibilities of the coalition and the work groups and subcommittees. We also have several new members on, so I'm going to provide a brief overview, and I hope that this addresses some of the questions. So the mission of the coalition is to bring together organizations and stakeholders to help implement the goals of the Cancer Control Plan. And the purpose of that is to reduce cancer incidence, morbidity, and mortality, as well as to improve the quality of lives touched by cancer. The structure is the Pennsylvania Cancer Coalition is structured as a committee of the Pennsylvania Cancer Control, Prevention, and Research Advisory Board, or as we call them, CAB. So the CAB is the umbrella, and the PCC is one of the committees underneath the umbrella. The coalition provides the statewide framework for implementing the plan, goals, and strategies through the work groups and subcommittees. Its governance includes the PCC co-chairs, as well as the co-chairs from each of the work groups and subcommittees. As you know, the PCC meets quarterly after the Cancer Advisory Board meetings. There is also a PCC executive team, and this team provides direction for the PCC and makes decisions on behalf of the entire membership. The executive team consists of the 2 PCC co-chairs, as well as all the co-chairs representing the work groups and subcommittees and the Department of Health staff. The executive team meets on the 4th Tuesday of each month following the CAB PCC meeting. And we do that to discuss what some of the questions are, any topics that came up or questions that came up from membership so that we can address those. And the dates of these meetings are listed on the pacancercoalition.org website. So the work groups are focused around specific cancers or cancer goals, and they focus on implementing the evidence-based strategies that are listed in the cancer plan. These work groups are organized by the big categories of prevention, screening and early detection, diagnosis and treatment, and quality of life. The subcommittees provide overall subject matter expertise on some cross-cutting issues in order to support and improve the effectiveness of the work groups. And you can see there we have disparities, evaluation, and policy. The Department of Health provides administrative support along with input and guidance to the work groups and subcommittees. The Comprehensive Cancer Control Program Director, now Brenda, meets with the PCC co-chairs on a scheduled basis to discuss the operations of the coalition and to provide any additional support or assistance as needed. Okay, next slide, please. So the next slide, the 2019 to 2023 Cancer Plan has 15 goals. The work groups and subcommittees were developed to work on one or more of the goals. You may notice that we did remove 2 of the subcommittees. They're no longer on the chart. And those subcommittees were communications and membership. So after much thought and discussion with the co-chairs of these 2 subcommittees, the decision was made to discontinue them because the work group and subcommittee provides updates and reporting will be incorporated into our regular PCC meetings. And because of these updates, we believe we can recruit more members based on specific strategies that the work groups are implementing. Additionally, the communication piece will be addressed through the quarterly meetings, as well as the pacancercoalition.org website. Again, I'm going to say I'm driving everyone to the pacancercoalition.org website because this is where you can find all of this information. All right, I'm going to now turn it back to Kate and Lynn to facilitate the report outs.
Great. Thank you so much, Becky. And yeah, just if there's questions that come up, we do continue to kind of share that update as we continue to have new membership. And it's always a nice refresher to kind of see how we're structured and really the important kind of framework that helps drive our comprehensive cancer plan. So now what we're looking to do is really have some open discussion as a coalition on the great work that is happening with each of our work groups and our subcommittees, as there's a lot going on. We know that this is something even through survey and just even one-on-one conversations that continues to be an important component to how we drive our work together, kind of hearing what others are doing and being able to just kind of dialogue and give support when needed, and even just that brainstorming. So we have done this sort of style in previous meetings, and we really wanted to continue to provide this platform for hearing a little bit about what's going on and driving some discussion, hearing those needs and all of that good stuff. So we are going to be really using the rest of our time as a PCC full coalition to really hear from each of our work groups and our subcommittees. Each of the co-chairs identified one of them to come off of mute and really share in a verbal fashion. So no slides. These will just be the same slide kind of for each of our work groups and subcommittees, for us to kind of hear these points that you see here. So strategies of this previous year, a win or achievement from the previous year, something that they may need, really looking to that support from us as a coalition, and really that discussion. So each of our teams will have about 10 minutes to not only hear some of that, but also do that discussion. So we're gonna get started. So first, this is the order that we're gonna go into, but we do have a slide holder for each, so we don't have to necessarily remember that order, but just giving a little bit of a taste. We may go a little bit out of order just in case. There are those that may be kind of coming in and out based off of previous commitments. So first up, we do have HPV vaccination, and our our voice for the work group is Dr. Callow. So I don't know if he is on yet.
Kate, this is Pam. I don't think he is. He said he's coming from his panel and he expected to be on at 9:50. So if you want to go to a next group, I know he'll appreciate that. And then I know Absolutely. He wanted to give the report.
Absolutely. So we will wait for Dr. Callow, and if we can move to lung, we have Casey, who is joining us, who will be speaking on behalf of the Lung Health Committee, or work group, excuse me. Casey, if you're here, if you would like to share.
Yeah, so this is Chelsea Hilbrand.
I'm sorry,
I
Chelsea.
will be sharing. That's okay, no problem. Yes, Denise Bluler was unable to attend, and I have stepped in as co-chair, as our other co-chair has recently left the American Lung Association. So would be happy to provide some of our updates for today. So first, our strategies for the current year. We are really looking and planning to continue our working with the regional tobacco cessation providers across the state that work with the Pennsylvania Department of Health, Division of Tobacco Control, and working with them to begin discussions about various radon trainings and introducing them to discussions about testing your home for radon, as well as when conversing with public about smoking cessation. So really making sure that when they're having conversations about tobacco in the community, that they're also discussing the importance of testing for radon. This combination approach of reducing lung cancer through smoking cessation and fixing homes will alleviate, hopefully, radon levels with a new approach in 2020 and ongoing for 2021. Our next strategy is really our year-round radon awareness campaign, an attempt to move from real estate-driven to cancer concern-driven option. So increasing media attention not only during National Radon Action Month, which is in January, but year-round. So we're really considering health system approach via cancer committee to adopt tobacco and radon as part of our lung health work group. Our third strategy is really identifying and promoting lung cancer screening education, activities, resources, and tools with our tobacco cessation providers and our lung health stakeholders throughout Pennsylvania to raise awareness and continue to increase referrals and access to lung cancer screening services for eligible individuals in need. So really working to collaborate with our other divisions in the Department of Health and their regional partners on how we can continue to incorporate lung cancer screening education into their services, as well as importance of radon education as well. So those are kind of a brief overview of our three strategies for the coming year. A win or achievement from the previous year. So this past year, Ron Myers, our big achievement is Ron Myers and his work on the lung cancer screening tool that he has created with the Jefferson University. So he created this tool. It was finished, I believe, at the end of last fiscal year, and they are now working on a new course called the Shared Decision Making in Lung Cancer Screening with the American College of Chest Physicians and Thomas Jefferson University. This is going to be a free online educational program on shared decision making to help identify and educate eligible persons for annual lung cancer screening. So I can be sure to share that link with the group as well. There are 3 modules. It takes about an hour to go through all of them. And this training program can be also accessed through the College of Chest Physicians on their website. So I'll share that link also. And there's a webinar coming up for more information about this shared decision-making tool that was created. So really excited that that has been produced and that our lung health work group member was able to do that. So really our barriers or challenge or need for moving forward from this group is really communications about this lung cancer screening tool. So we would really look to the rest of the group to help us in distribution of this training to healthcare staff and people that are interested in learning more about lung cancer screening and that shared decision making meeting that is so important to have with healthcare professionals. And I know that was less than 10 minutes, but those are our updates for today. So I don't know if there's any questions, but we'll be happy to include some of these links in the chat box for the rest of the group to see as well.
Fantastic. Chelsea, thank you so much for that overview and really sharing on behalf of the group, and welcome into this new role as co-chair to this lung health space. There's so much going on in the space of lung screening, cancer, all sorts of stuff. So just kind of hearing all these things that are going on are really, really a rich amount of information. There is a question that's coming into the chat. I'll read that for you. Are there any statewide resources for free home radon testing kits? So I think that's you or even others that might be able to support that question.
Yeah, so Denise Bluler, who is my co-chair, she's works with the Department of with DEP, and she has more information specifically about free radon test kits. We have been with our lung health work group. We have various avenues where we've been able to share free test kits across the state. So I will be sure to follow up with you on where you can request that and put Denise's information directly in the chat box so you can contact her as well. I'm not sure if there's anybody else on our work group who specifically is focused on radon that would like to potentially add any information in the chat box as well for Laura, but Laura, we'll be sure to follow up about statewide resources and home test kits for radon.
Great, thank you. Other questions for Chelsea and the lung health team? Fantastic.
Hi, this is Eric Rossimo from the Harrisburg Area YMCA Center for Healthy Living.
Hi.
I just wanted to mention, as part of the lung health group, that we have been distributing radon kits on our health equity tour. We're 30 plus stops into the tour, and we've given out around 600 kits already in various counties. The highest county so far where they've been distributed was Erie County, where we gave out 50 plus kits in that county for people to test their homes for radon. Between myself and Denise, I report back to Denise at Department of Environmental Protection. She is keeping track of how many actually come back from the kits that she provides for the tour. So in the months to come, we'll have a better report. I'd say probably 6 months out on the results of all the tests distributed from the YMCA and Penny Health Equity Tour. And we'll have those outcomes of how many actually came back and those radon levels.
Great, thank you. We look forward to hearing that. Final call for questions for the lung health team. All right, well, again, thank you, Chelsea. Okay, if we could go back 2 slides to the HPV. I see Dr. Callow is on, so if I could give you the spotlight to talk about the HPV work group and hear the questions for that verbal report out and discussion.
Good morning, everyone. Can you hear me?
Yes.
Perfect. Thank you for the invitation. Sorry for being late. I was teaching today morning. So I want to report on behalf of our HPV work group. Pam is here. I just want to I just want to highlight that I'm going to be giving some specific examples. We have been doing so much progress in the last year. So sorry if I missed some of the important work that some of our partners are doing, but please feel free to just chat, include something in the chat if I'm missing something. In terms of the strategies that we're using in this 2021-2022 fiscal year, I want to mention 3 of them with some specific examples. The first one is that to disseminate and implement evidence-based strategies specific to improve the way providers recommend HPV vaccination and to increase the utilization of reminder and recall systems. And more specifically for catching up with those kids who haven't received the vaccine in the past year. We know COVID-19 have been having some issues with receiving appropriate care, especially for adolescent vaccines. One of the specific initiatives that we have been doing is the launch of the HPV Vaccine Communication ECHO program. And that's one of the interventions that we're delivering here from Penn State. This first year, we recruited 6 clinics to our no-cost training, and those 6 clinics have been present in our sessions. So far, we have trained 27 clinicians, including family physicians, pediatricians, and nurses. Next year, we plan to increase that number from 6 clinics to 15 clinics in 2022, and in 2023, increasing from 15 to maybe 20. So in total, we plan to deliver our training program to around 45 primary care offices here in Pennsylvania. That's strategy number 1. Strategy number 2 is to promote and educate systems, providers, other healthcare professionals, parents, and other stakeholders about the importance and benefits of HPV vaccination as a cancer prevention strategy. And for this specific strategy, I want to mention 2 programs that have been launched this year. The first one is from Temple University. Christina Reardon just finished the dental HPV model in partnership with the Department of Health. And this model is going to be a training model, will focus on education for dental students on HPV vaccination as cancer prevention. The second strategy that I want to mention in this area is that the Hattiesburg YMCA launched their 2021 Health Equity Tour in summer of this year, and they went to all 67 counties in the state, and they include HPV vaccine education, and in some areas, vaccination as part of that offering. So those are our 2 main initiatives in this strategy number 2. The last strategy that we have been working is to better utilize all data resources available for HPV vaccination. And for that one, we're continue utilizing and improving the capacities of the state immunization registry. So those are our 3 main strategies and some of our main projects around those 3. In terms of wins, we have many. I want to just go back to the amazing work that our dental group is doing. We have within the HPV Work Group, we have the dental HPV subgroup, and they have been making for the past month tremendous member growth and supporting our main initiative in the main group. Second, there's also the addition of the Western HPV Task Force. They join our monthly HPV Work Group calls, and they're focusing on the HPV initiative in Western Pennsylvania. Also, I want to highlight that in March 2021, we celebrated JDC Pediatrics in Inola. They hit the 70% HPV vaccine completion rate by age 13. So that's a major accomplishment. One of the few clinics in the state who have been meeting that target. Barriers, challenges, and what we need. I want to mention 2 of those briefly. The first one is related to the dental group. One of the things that they try to do is to offer, of course, HPV vaccination in dental offices. But there's an important question that they need to address first, and that one is related to the scope of practice. So they have been in conversation with their dental board to better understand if delivering HPV vaccination is part of their routine scope of practice, and they have that have important implications moving forward if they're going to be able to offer or no HPV vaccination. And the second thing that is just happening across the state is, as you know, COVID-19 pandemic have been having a really high toll on many of the preventive services that we offer. Although NIST data show that overall HPV vaccination, both initiation and completion, increased in 2020, the data that we receive is pre-pandemic, is data until March or April 2020. So we don't have the real, we don't know the real effect of the pandemic in the last years of 2020. And as we know from some of our data, there have been a decline in the purchase of HPV vaccines, especially for those offices offering vaccines through the BFC program, the Vaccine for Children program, funded through the CDC. So we don't, although we have some good news that pre-pandemic vaccines have been increasing, we don't know the actual effect of the pandemic. So it's gonna take maybe a year or 2 years to better understand that. And that's my report. I just wanna know if there's some of my colleagues from the HPV Work Group who would like to add something that I may be missing.
Thank you, Dr. Callow. That was really, really great. And there's so much work coming out of the HPV team. You guys are really, gives a lot going on for sure. Questions or just things to kind of shout out to the group regarding HPV vaccination?
Kate, this is Pam. I just want to give a thank you because I know we have so many people in the main HPV work group and then so many in the dental subgroup, but just thank you to everyone. The groups are so engaging and the conversations are just amazing. So we've got some really, really strong stakeholders, and just want to, you know, Dr. Callow and I just want to continue to say thank you to folks because they show up, they're on the monthly calls and very, very engaged.
Absolutely, Pam. And in thinking about a time when, you know, just kind of the encouragement of HPV vaccination, there's so much great things that are going on, and that encouragement and the urgent kind of call to action is just great to see what we are seeing in the state of Pennsylvania and the resources that all of you are putting out there to make that happen. Last call for anything to the HPV work group. Okay, well, thank you again, Dr. Callow, for that report out.
Pleasure.
Great, awesome. If we can now go to the colorectal cancer work group. And of course, you know, as we go through this, I'll do this kind of shout out as we go on, but continue to utilize the chat as we kind of go through, because something may pop to mind as we move through our different report out. So please continue to use that. So Lynn, I'm going to turn it over to you to kick us off for colorectal cancer.
Thank you, Kate. And it's great hearing the first two groups. Colorectal cancer work group has been co-chaired by Kate and myself, and we've been trying over the last year, almost year, to obtain new co-chairs. I have been asked to stay on, and I've agreed to stay on, but I do still need a co-chair to the group. The group has been meeting, but it's been a small group, and we have a lot of work to do, and there's a lot to be done with colorectal cancer. So we really are in need of some new, motivated and engaged members. But what we've been focusing on have been sharing best practices among the members and highlighting modalities and strategies that have really worked well for some, and sharing things that didn't work so well so that individuals can move colorectal cancer screening forward wherever they are or in their institutions. We've also been getting tools and resources out to the members that are surrounding screening. And we very much have been focusing on one of our big wins, or aims, I should say more so, over the last at least 6 months has been to explore ways to effectively engage various constituencies to develop and implement ways to support the various practices to ensure colorectal cancer screening. So we're looking at actually trying to bring healthcare plans and healthcare systems together to collaborate on these issues. Another thing that just happened yesterday, and I'm just going to lightly touch it because I don't want to take everything away from policy, but I met with Emma and Ruth from policy and April Barry, and there is the opportunity actually to hopefully start to move a policy surrounding colorectal cancer loopholes forward. At least we're going to try statewide. And what we want to address is follow-up coverage for colonoscopy. So in other words, individuals very often that may opt to have a stool testing, then it's positive and they need to go on for colonoscopy. This is no longer being looked upon as a screening colonoscopy but a diagnostic colonoscopy, and then the individual is being left with a rather hefty copay or bill. So there's more work going to be done in that direction to see if we can move that forward across the state. It won't be overnight. So I think the biggest barrier that we have is we need more work group members, and we need them engaged and committed so that we can continue to move colorectal cancer screening forward. Colorectal cancer is a cancer that we could practically eliminate, at least 99% of it, if individuals got screened. I personally have a very active colorectal cancer screening program, and I think others could very easily implement it in their areas if they joined us and we could all work together. So that's where we're at. And we still need a co-chair. So if anybody's interested, please let me know or someone know on the PCC. Any questions, comments, suggestions? Kate, you've been a part of the group. So if there's anything you have to say, please join in.
Sure, absolutely. And in just thinking about a lot of where we've been with the sharing of best practices and kind of understanding where many of our previous membership has been during these last almost 2 years through the pandemic, really kind of strategizing how folks have really been reacting to kind of overcoming some of those barriers that were put forth right at the beginning end of the pandemic. So that's where the sharing of these best practices, the innovation that has come across the state, and sharing and dialoguing on how we can really kind of do this together. And couple that with what Lynn had shared around kind of eliminating some of those barriers and loopholes as we are trying to really kind of encourage and build that confidence with screening. So there's a lot of still things going on, but to echo Lynn, just kind of the power of how we are doing this and have done this before together. We are looking to kind of get those roots again. So yeah, any thoughts, comments, discussion, we would really welcome that.
Hi, this is April. One of the additional things that we are looping in with the Colorectal Cancer Work Group is the development of a web page on PAcancercoalition.org for resources for businesses and employers to not only support colorectal cancer screening, but all of the screenable cancers. So stay tuned. It is a project, and we're hoping sometime around November to have it completed. Thank you.
Thanks, April.
Any other thoughts, questions to the Colorectal Cancer Work Group? Great. Thank you, Lynn. And we can go to the next work group then. All right, we have Fern who's going to share out for our men's health team.
Sure. Hi there, everyone. Good morning. Good morning. So our strategies for the men's health work group are to continue working through our 4-prong plan, which I'll go ahead and quickly review that for those folks who may have missed that review before or who might just need a refresher. So basically our plan is to promote screening for lung, prostate, and colorectal cancer, specifically among Black men, and also focus on getting Black men into the healthcare system to see providers for cancer screening. as well as other issues and general wellness checks. The main vehicle for this is the development of an online module specifically for community health workers that will focus on cancer disparities and data, then teach community health workers how to engage with clients to get them screened, get them to their primary care providers, and then also to connect with providers to prime them to understand this effort and what to do when they see folks who have come to them for this purpose through CHW. So it's sort of threefold. It's a threefold approach. The next prong is the development of tools for adolescents in settings where young Black men are a significant population. And this is specifically for the purpose of teaching them family history curation and the importance of taking responsibility for their health by knowing health risks and understanding harm reduction and protective factors. The next prong is the promotion of better protections for communities of color that suffer greater rates of health problems, often due to close proximity and regular exposure to sources of toxic waste and other carcinogens. And those sources might be landfills, power stations, factories, waste facilities. Radon is included in that, pesticides, fungicides, herbicides. And then the last prong is the expansion of this work group to be even more inclusive and representative of community members that experience significant health disparities, those who specialize in men's health, in particular, are focused on prostate, lung, and colorectal cancers, and keep expanding with those rooted in communities that are at risk and who understand community needs. So we've really spent some intentional time setting the stage for this plan, as it's pretty robust, but we're very committed to it. So Brian, my co-chair, and we meet bi-weekly, and we just talk about where we want to go with things, how we want to, support the team. It just really keeps us accountable for staying connected and moving this robust plan forward. We are meeting with our team monthly. We've had one meeting so far. We're going to have the next one soon. And I do want to say that part of what Brian and I have done is center, and we brought this to the team and the team's on board, that centering this work on actually a play by a woman named Sonia Sanchez, and the play is called Aha, but How Do It Free Us? And this helps us to move through the work plan with guiding questions based on this concept. So the guiding questions for us to keep us sort of focused and moving forward is, the bottom line of these questions and this plan is how anything that comes up, questions, directions, concerns, how does it free us? How does it serve the community? How does it serve to prevent cancer? And it just really is a barometer to keep us on task. So we use that as the bottom line, as the sort of framing for moving forward with the plan, to be clear. So far, in addition to the team meetings and the bi-weekly meetings with Brian and I, we've met with the Disparities Work Group, where there's a lot of room for collaboration and crossover there. We met with Kate from CanSun, and we discussed ways that we can collaborate and support each other. And our team is going to really delve into looking at the EDDI and start working through actionable steps and using that as an instrument for doing that. And we're also connected now, just emails and receiving information from the Cancer and Environmental Network of Southwestern PA. A win or achievement from the previous year is that we were able to reassemble the team, and we have, I think, 8 active members now, and they're great. They're super invested in the work and very, very committed, and our hour-long meetings go by very quickly. A barrier, challenge, or need, we're definitely going to draw upon the other work groups here to ask for feedback and support as we get more into the work plan. So you'll be hearing from us. And That's what I have to report. Does anyone have any questions?
Thank you so much, Fern. There's a lot going on, and it's, you know, just even how you've been reflecting on the collaboration and the potential collaborations and stuff like this. Really great stuff that's coming out from your team.
Thank you so much. Yeah, we're very excited to move forward. It has felt sort of like, you know, setting the stage and rebuilding the team took a while. But as I mentioned, Brian and I were extremely intentional about it and really wanted to make sure that that strong, solid foundation was laid before we moved forward with the team. We felt, you know, a great responsibility to make sure that we're using people's time wisely and intentionally, and we're doing it in a way that's only going to move the plan forward. So thank you.
Thank you. Questions, comments for the men's health team? Fern, you have a comment in the chat, and thanks for getting the men's work group up and running again. Great job.
Oh, thank you so much.
Hello.
Yeah.
This
Thanks
is
for the partnership, Sharnita.
Hello. Can you hear me?
I can hear you. Yes.
This is Lynn Becker from the Tobacco Cessation. Excuse me, the Tobacco Prevention and Control Division, and we are in the process of planning a special project for. Well, I don't have the exact title yet, but it's something along the lines of developing a culturally appropriate cessation opportunity for Black males, Black men. So we're going to be following a methodology that I saw presented at APHA a year ago, and I'm very excited about it. But you'll hear more as this goes on. We'll keep you informed. But it was approved that we would begin this, and we'll start probably around November-ish to start to get it off the ground. But we will be focusing, at least one of our projects will be focusing on Black men and helping them to quit smoking.
Oh, Lynn, can we meet and talk more about that?
Sure.
That would be great.
Thank you. This is Fern. Okay.
Yeah, this is Fern still. Yeah, thank you so much for sharing that.
Mm-hmm.
Other questions or things to share with our men's health team? Okay, well, thank you again, Fern, and again to the group. If there are questions or comments that still come to mind as we move through our report outs, please feel free to continue to utilize the chat. All right, so next we have Andrea to talk about our cancer genetics and genomics.
Hi, everyone. Can you hear me?
Yes.
Great, excellent. So I'm Dr. Andrea Durst. I'm one of the co-chairs for the Cancer Genetics and Genomics Work Group. And I wanted to start by talking about a win or achievement from the previous year, because I'm very excited to announce that our provider toolkit, which consists of resources that are related to hereditary cancer syndromes, specifically focusing on hereditary breast and ovarian cancer syndromes, as well as hereditary colon cancer syndromes, has been published online. So it's under the news and resources section of the PCC website. And I'm also going to put the link here in the chat for that. So we were really excited to have that finally be completed and approved and put up online. It was such a collaborative effort between all of the members of our work group. And so I thank everyone who has been a participating member of the work group for all of your contributions to that toolkit. We're very excited about that. So I've included the link here. So our strategies for the current coming year, our work group is planning to start meeting more regularly. So over the course of the past year and a half with the pandemic, our meetings have been more sparse. And so now we're setting up kind of regular recurring meetings, and we have several projects that we are going to be working on. So the first is to complete our toolkit for the public, so public-facing toolkit on hereditary cancer resources. So again, the one that we just published is geared toward providers, and so this one will be geared toward the general public. We do have the colon cancer piece of that finished, and so we just need to complete the hereditary breast and ovarian cancer piece of that, and we have some work group members who are really interested in kind of bringing that to completion. We're also going to be conducting a needs assessment survey throughout the state to determine what are the barriers to accessing cancer genetic services, both for providers and potentially also for the public as well. We plan to establish a subgroup to work on specifically that needs assessment survey and getting that distributed across the state. And then finally, we have several projects where we're going to be just working on developing additional resources to put up online on our website, and then also to periodically review the web analytics to determine the use of our resources. We also have a plan in place to continuously update our published toolkits as well. So we'll be looking at those and updating them multiple times each year. And so with that, a barrier, challenge, or need that our group has, so please help us to get the word out about the toolkit. Please feel free to distribute it widely to any healthcare provider practices or organizations that you are involved with. We're also happy to talk about maybe constructing a specific kind of introduction for a particular stakeholder to point out the things in there that might be particularly helpful for them and their patient population. So if you are interested in that, please get in contact with either myself or my co-chair, Dr. Alana Ram, or April Berry, and we can help put together some introduction materials that can be included maybe in an email with the link. And we're also happy to follow up with organizations as well. So please help us get the word out on that. And then also when we do complete our survey, we will need assistance in also distributing that across the state. And so hopefully more on that will be coming in future meetings.
Thank you, Andrea. There's so much going on here, and certainly a lot of excitement for the toolkit and kind of hearing how that has been in development and how we can use that to really get this out there is really exciting. So thank you to you and the team for all you've done to really make this happen.
Yeah, it's been a really exciting project to work on.
Fantastic. It does look like we also have questions. So Evelyn, if I could ask you to come up on mute and ask your question.
Super. Thank you, Kate. You know, just in listening to this report, one of the things that occurred to me that might be something we want to consider moving forward as a PCC is, you know, the community health needs assessments that are being conducted by nonprofit organizations and in particularly hospitals. There is an opportunity to ask questions regarding, you know, whatever is of interest to you. So, for example, this year, Fox Chase is collaborating with 8 other institutions. We're going to be doing a regional community health needs assessment. The past 6 years, we've been doing an individual one. But we have a meeting, in fact, this afternoon, because whenever Fox Chase does theirs, cancer is all that we do. So we're very focused in the type of information we're trying to collect. So we ask cancer-related questions in addition to all the broader questions. But it would be really great if, as a PCC, we could come up with some standardized questions, such as the ones that were just presented, like barriers to genetic services or specific barriers, which is one of the questions that we do ask. And it would give us a really nice overview statewide of what's going on. So I just kind of want to throw that out as a potential item that we might want to consider sharing with all the hospitals in the state that are required to do this community health needs assessment. I think it would really give us a very broad and view of what some of the challenges and issues are. So I just kind of wanted to throw that out there as an idea.
Evelyn, thank you so much for sharing that. I think that's a great idea. You know, I think it would be great to try to include some questions on something that's already going out to a relatively large portion of the state, it sounds like. So I think that would be great.
Yeah, I mean, every nonprofit hospital is required every 3 years to do this. So if we're all asking the same question, I think that would be really great.
Yeah, absolutely.
Thank you, Evelyn. Other questions for the genetics genomics team? All right, well, thank you, Andrea, and just really great stuff. We look forward to this toolkit and what we can do to get the word out on it.
Thank you.
Great. All right, so for our work groups, our last report out before we switch over to our subcommittees is survivorship. So we have Amy who's going to share on behalf of the team.
Hi, thank you, Kate. Stephanie and I have been meeting with a lot of different individuals within our PCC. So thank you all first and foremost for answering our questions and our emails to kind of figure out and gear our direction of where we want to go for this current year. Primarily what we are still working on is really having those meetings and discussions regarding existing statewide resources and websites throughout, and where we need to fill those gaps in reference to survivorship and those that are Pennsylvanians living with or beyond cancer that need resources. So in the past, we've had those individuals reach out to us saying that, there's really no cohesive place for them to get access to what's available resource-wise within the state. So that's something that we've been developing, and we're going to also be fielding some type of survey related to that. As far as our physical activity portion of our work group, we are ensuring to find out all the different types of programs that are available to those living with or beyond cancer in the state. Obviously, having Live Strong at the YMCA, like we discussed in the past, a portion of that. We were very thankful to the Department of Health and Temple for helping us create a platform within their Canvas system that we are currently doing a virtual class cohort with some cancer survivors that way. We're also going to be kicking off in-person programming again, and that will be, just another way of one of our goals of getting Pennsylvanians up to that 150 minutes per week of physical activity. That is our goal. We met with Kate with CanSun, as you guys have heard a little bit about already, to discuss some possible collaborative efforts. So we're looking forward to continuing those discussions, and she'll be presenting at our meeting coming up here. So we were doing monthly meetings. We moved that now to being bi-monthly, as we figured we have now gained a pretty good membership and are still gaining more members. So if you know of any entities that would want to sit with us on our survivorship committee, please send us and let us know, and we'll reach out to them as well. We're really trying to look into getting physicians or doctors that have involvement and would be interested in the survivorship area to kind of give their perspective. One of the main exciting things too was that we were able to have an actual cancer survivor who is one of our volunteers as a Live Strong instructor join our group. So she's great with giving the perspective from someone that's actually been through cancer treatment and is also a metastatic cancer patient. So that's great insight that we have for anything that we're doing. As far as everything else goes, a win or achievement from the previous year, I would just say finally getting to the point where we feel like we've built out our membership within our work group and having consistent meetings scheduled moving forward. So we're really excited to kind of get down now to the nitty gritty of what our goals are and moving forward with our plans in the future. A barrier, a challenge, or a need. So that's just, we've really, we're trying to figure out how we can complete this survey to get to know what resources are needed and what resources are out there. So that's something that we're going to be, exploring. So it sounds like we might be tapping into the genomics work group here shortly as well. I'm going to talk to Stephanie about that as she's not able to be on this meeting. So I'm sure we'll be reaching out to you guys shortly here. But that's really, we're excited with the future and what we have and what we can hopefully accomplish here. So a lot of stuff has been happening, and we're, starting to find our footing and being able to attack our goals. But that's about it that I have for survivorship.
Thank you so much, Amy. You have a lot going on, and even just kind of hearing some of those things that you and team have been working on to get us even to this place. It's great to hear those things.
Thank you.
We do have a question that's in the chat. So this may be just one thing. It's just really kind of the best contact for those that have anybody that might be of interest in the work group. Just like should that be you and Stephanie? I'll just kind of leave it to you to give guidance on this question.
I just saw Pam's chat. I will reply to her. So thank you. Yeah, it would be me and Stephanie, and I'll give that contact information right in the chat. So thank you, Pam, for reaching out.
Because I'm sure that may be on others' minds as well. Fantastic. So other questions or just comment to our survivorship team?
Yeah, Kate, this is Evelyn. I have a question. If I heard correctly, you're working on working with different survivor groups. Is that correct?
We have survivorship programming related to physical activity and beyond. So part of it is a physical activity goal and getting cancer survivors, or Stephanie works with Living Beyond Breast Cancer, and their terminology that they like to use is those living with or beyond a cancer diagnosis. So that we have groups within that for the physical activity programming, but we have pulled in individuals that are diagnosed with cancer, and they're actually sitting on our work group. So we're going to be reaching out to cancer survivors to try and get their input on what types of resources they need and can utilize. So then that way we're making sure that our resource engine or whatever we come up with to be able to put those resources. So we've tapped into Neighborly through Geisinger, Aunt Bertha, PA211, different things like that, and making sure that the resources that are needed for cancer survivors are listed on those different engines and they can readily find them.
So I guess the root of my question is really based in diversity, just to really make sure that the team is, when we're approaching different teams, that we have diversity not only in urban and rural, but also in race and ethnicity, because the needs will certainly be different. So I just kind of want to put that out there.
Absolutely. Yes, that is something that we are keeping in mind with the reference of health equity approach and all of that. Yes, very good point. Thank you.
Thank you. Other questions, comments for the team here? Okay. Well, thank you, Amy, so much for sharing on behalf of the survivorship team. Before we go into our subcommittees, I just want to kind of reflect on what was reported out from our work groups and just really thank all of you for speaking on behalf of the teams. And just kind of as we moved through the report outs, we tackled prevention, early detection, diagnosis, treatment, and quality of life. So we really are covering a lot of what is the comprehensiveness of cancer and the care of our patients across the state. So thank you for that. And just again, continue to utilize the chat, or I'll kind of also do a call out for any kind of other questions related to the work group report outs that you just heard. All right. So we are going to now move into our subcommittees, and we're going to be heading into this order here, kind of the same format. They'll have each about 10 minutes, same questions to present a bit of a report out to this team and allow us to dialogue. So first up, we have our disparities team, and Evelyn, you will be speaking on behalf of our subcommittee.
Yes, great. Thank you, everyone. Good morning. So on behalf of the Disparities Committee, I just want to tell you a little bit about what we've been working on. So prior to Sharon Sowers leaving, one of the tasks that she asked us to begin to work on was the development of a report focused on Black or African American men's health in regards to the cancer burden in the state of Pennsylvania. Oftentimes the Department of Health is asked by the legislature to present specific information. And so they were looking for something that they could hand legislators and policymakers, like a 1 or 2 page item that they could easily present to them. So that's one of the tasks that we're working on, but the broader one is a larger report that will be more in depth. So that's what the team has been working on, and we're starting this report on prostate cancer for Black and African American men, and then we'll move towards lung cancer and colorectal cancer. And during our conversations with the team, other topics have emerged, such as the concern for increases in liver cancer in the state and bladder cancer. And so, time allowing, we will certainly check into moving to add those particular pieces as well. Team members have selected the areas which they think they can contribute to. So we have a data and statistics assignments, literature review, risk factors, barriers, identifying evidence-based strategies, the writing team, and the review team. So that is kind of how we're moving forward. And we're very excited because actually over the last 2 months, we've actually gained like 5 or 6 new members. So we feel like this will really help move things, accelerate our progress. So one of the challenges that we had was we've been waiting for the Pennsylvania Chronic Disease Report, which was pending review and publication, but we're happy to report that we did receive it last week. And so we will certainly be using the data presented in here and make sure that it aligns with the data that we're putting together. And during our last meeting, Charnita, who's co-chair of this subcommittee, prepared and shared some of that data to us to help us really understand the scope of the problem here in the state of Pennsylvania. So we're very excited to have that data and to begin to work around it. We will now move into our literature review, which will help us identify our strategies. And obviously, we know the risk factors, but we're also going to be paying special attention to not only the reports that were presented today. We're going to need to link and work a little more closely because it sounds like other groups are working on similar efforts. So we don't want to be duplicative. We really kind of want to begin to collaborate a little bit more on this. And we will also be including things such as the Pennsylvania Prostate Cancer Task Force recommendations. So there's some historical work that has already been done that we don't want to lose. We want to make sure that we're being comprehensive and that we are actually showing our legislators that, you know, the stuff that they were supporting has been referenced and we're looking at it. We haven't lost sight of it and that we're building upon it. some of the challenges that I think that we've had, obviously waiting for the report, but I would say it's always competing, responsibilities and duties that we all have, and time. Writing takes a lot of concerted effort. So that being said, I think with the growth of our team members, and we are going to be developing some timelines and deadlines to help us move this process forward. I think we will have some great traction moving forward. So those are our strategies. And I think in closing, I'll say that it's really wonderful to hear all the work that's being done at the state and on these teams. And for Charnita and I think we'll probably be reaching out to you to make sure that our work is aligned and representative of all of our groups together. We are already working with the men's working group, so we're very excited about that. And some of the other comments that have been made on our team is also really bringing in other entities such as the Pennsylvania Department of Health's Office of Health Equity, which also is not only interested, but is trying to really educate the consumers of this state about multiple chronic disease burdens. So we want to make sure that we're represented in that. And that is all that I have. So if anyone has any questions, please feel free.
Thank you, Evelyn. Got some things going on in the chat. Just, of course, the call out for excellent presentation and just the reaching out to, different components of our work group. And even just thinking about just those reminders and just the work as our subcommittees are cross-cutting, they really reach all of the work that we are doing. So these are great reminders and just that sort of component to how we are more collaborative together, or even just those things that we are ensuring that we are building into our plans that make things much more equitable as far as execution of this work. So thank you for that. Other comments, questions for Evelyn and the team?
Thank you.
Great. Thank you, Evelyn. Okay. So next we have our evaluation team. And so Heather, if you're here and want to talk a little bit about this work. Heather, are you there?
If she says, no, I want you to do a groupie.
We can come back to evaluation. We'll just give a moment. And if we want to move to the policy team, we have Ruth, who's going to be speaking on behalf of policy. Ruth, are you there?
Okay. Yes. Can you hear me well enough?
Yes.
Okay, thank you. So kind of an update we presented to the group a few months ago, and so I'd like to just hit a couple of highlights there. As far as our goals for the upcoming year, we look to continue to work with the PCC work groups as opportunities arise through their work where policy may play a role. We continue to build our partnerships within the PCC. And I wanted to also put a little plug in there for our group. We meet the first Tuesday of every month from 9:30 to 10, and we generally come in at under 30 minutes. So just to let you know that it's not a huge time commitment if you want to be involved. Our wins for this past year is that we've continued to build our membership. We have about 30 members now. And the other big win is the developed relationship with the Cancer Caucus, which we did mention in the last time we presented. So corollary to that is, and something that Lynn mentioned as well, is when we did meet with the Cancer Caucus,
Ruth, if I could interrupt just one moment.
Sure.
If you are not speaking, if I could just kind of do that call out for muting your line, just to reduce that background noise, that would be wonderful. Great, thank you. Ruth, back to you.
Thank you. So one of the big points that when we did meet with the Cancer Caucus was really the implications of COVID and the impact that it had on cancer screenings. And the major point of discussion in that meeting was that there was a drop off in cancer screenings and the impact and potential for late stage diagnoses and unnecessary cancer deaths. And this leads into, as I mentioned before, what Lynn mentioned, is the colorectal cancer is really one of those cancers that is truly preventable through its screening process. And so it really becomes very cost effective to encourage this type of screening. And a lot of people kind of assume that the colonoscopy is covered, and indeed through the ACA, was required that all private insurers and even in Medicaid expansion states to cover without any cost sharing these preventive services that receive an A or a B rating. So with regard to colorectal cancer screening, an A rating was given to both colonoscopy and stool-based tests like the FIT test or Cologuard. And then obviously if a stool-based test comes back positive, it's recommended to get follow-up colonoscopy done. The problem that's arising right now is that some health insurers are considering that follow-up colonoscopy as a diagnostic test rather than a preventive screening test, and patients are receiving bills with regard to that. And so we are looking at, and we've seen that several states have already considered a policy solution and have passed legislation that would require plans to cover that follow-up colonoscopy with no cost sharing if it's based after a positive stool-based test. So it's been passed in Texas, Kentucky, Maine, Oregon, Arizona, and Rhode Island this past year. There are currently bills in the process in California and New York. And so the other aspect, and people might be saying, well, why are people getting these stool-based tests? Well, the reality is they're much less expensive and much more patient preferred. They're minimally invasive, and they have shown to result in higher screening rates, particularly in rural communities. And because of the lower health costs for both insurers and patients, it's just like a really great way to bring people into the screening process. So right now we're exploring an opportunity to introduce legislation into Pennsylvania that would remove the cost sharing associated with those follow-up colonoscopies. And certainly if any of you or your organizations that you represent would be interested in supporting or learning more about this, please let us know. This is one of our goals for the upcoming year. We also appreciate, and we talk about our barriers. I think for us, for policy, our barriers is it just takes a long time to get this stuff kind of going. And so as soon as we can build other partnerships or supportive relationships for things that we're considering, we certainly welcome that early on in the process, of which we are very early on in this. I think in April, I think you can speak to this. We're going to kind of put a little request out after this meeting, or as a follow-up, encouraging people to reach out to us if they are interested in being part of this.
Yes, we had talked about, we will be working on developing an email blast for what Emma's needs are, to partners to join the initiative to close the loophole and get healthcare and hospital systems on board with this possible legislation in time that would be proposed. Thank you, Ruth and Emma, for all your hard work on this.
Thank you. So that's, if there aren't any questions, that's where we are.
Ruth, thank you, and to the policy team, and really for what you're doing and what's on the horizon. As we know, kind of as we talk about equity and just reducing barriers, there's a lot that we can do through our policy endeavors that just really kind of can take, like we are even talking about here, some of those loopholes out of out of the mix to allow decision making on many, many angles become much more easier for not only the patient, but for the care teams that are supporting them. So thank you for all of this, and to everybody that is working together to really make this happen. We know it takes a long time, but it's certainly worth it in the end. Comments, questions for our policy team? Okay, well, thank you, Ruth. And, you know, just, we can go back 2 slides, please, to evaluation. One more. Perfect. So Heather, if you are available to hop off of mute, I know we had a little tech issue, to share on behalf of the evaluation team.
Yes, I can share. Sorry about that. I did have a frozen Teams and I wasn't able to unmute myself.
Thank you, Heather. We know those tech issues all too well.
So the strategy for the current year for the evaluation subcommittee is, of course, our role is to evaluate progress on reaching the cancer plan goals and to understand how the PCC is functioning. So in support of that, we just turned in the 2020 to 2021 evaluation report to the Comprehensive Cancer Control Program staff. And we're on the agenda to discuss those findings in December. So I'm not going to spoil them now, but you will hear much more about that report then. We're also in the process of updating the cancer plan report card, which measures progress on those 15 cancer plan goals that we talked about earlier in this meeting. And we do plan to again evaluate PCC member attitudes about these quarterly meetings after each meeting in a 3-minute survey. And in the spring, we will again launch the PCC annual survey. And we are interested in collaborating with other work groups and subcommittees if they have evaluation needs that we can possibly help with. A winner achievement from the previous year, we have a huge win thanks to all of your help collectively. We had 112 people who participated in the annual survey this year, which is almost 3 times as many people as previous years. So thank you, thank you, thank you, thank you to everyone who participated in the survey, all the co-chairs who encouraged their work groups and subcommittee members to do the survey, and also for Sharon, who tirelessly promoted the survey. All of that participation was really key, and it really helps us understand what's going on for PCC members. And again, we'll be on the meeting agenda in December to discuss more of those findings then, so stay tuned about that. In terms of barriers, challenges, or needs, first of all, we would love to extend an open invitation for anybody in the PCC who's interested in evaluation work. The evaluation subcommittee welcomes participation from all PCC members. We try to keep routine communication alive. We have a monthly meeting, and we try to be mindful of busy schedules and have really compact but productive meetings. So please let me know if you'd like to join the evaluation discussions at any point. I'll put my email in the chat once I'm done with this little report out. Way that you can help, number 2, is when the time comes in May, June of 2022, we really want to see participation in the annual survey grow even more. We want to blow our previous record out of the water. And these responses really do get used by leadership. You've already seen how Becky took some of the findings that we just turned into her to review, hey, here's the structure and function. Make sure everybody's on the same page here. And number 2, after this meeting, we're going to send out a meeting evaluation once we get everybody's email addresses who was able to come or sign up. So if you can complete that, it should take 2 or 3 minutes. And again, the leadership really does consider all the feedback that we get through those surveys as well. And I guess now I'd be happy to open the floor to any Q&A that anybody might have from the evaluation subcommittee or comments.
Thank you so much, Heather. And I'll just kind of echo your words here, and just, the value of these surveys that are put out. The evaluation of this is we really do want to hear from our coalition memberships on what would be meaningful to you. As Heather expressed, that does, it is a value. We are looking at, we look at ourselves as in a constant state of improvement. So even if you have constructive feedback to share, the more specific that can be, that is very helpful as we are responding to even some of the feedback that we have heard from others by the content that we're building into our meetings and the style in which we are delivering them. So I'll just kind of throw that echoing of your words, Heather.
Thank you so much, Kate.
Other questions, comments, or discussion to be had with our evaluation team? Great. Thank you so much, Heather, and to the team for all that you are doing to support our strength as a coalition, and to the different ways in which we are kind of seeking those guidance tools to drive our work in this comprehensive cancer plan forward. And thank you to all of our leaders who reported out today. Really, the work that is going on across our subcommittees, our work groups, is just tremendous. Not only what you're doing as a team for this coalition, but also what you're doing in your own worlds. I think, through all of this, each of our plates are really runneth over, if you will, with different things that we have going on. And just your commitment to this, the work that we are doing together is really, there's not enough words to thank all of you for what you do day in and day out. So Monica, if we can move to the next component of our agenda today. Okay, so we're coming right up on top of the hour of 11 o'clock, and we, wanted to give this time for us to dialogue and discuss really just what is going on amongst our different teams, as well as just us as a coalition. So before we do our wrap up and closing, I will just do a final call out for any questions that we do have from our membership to any of our reports that we heard today.
Kate, this is Lynn. I don't have a question, or it's more of a comment. I just am really, really thankful, plus kind of really excited, because all of this work that's done by all the work groups and committees, etc., is all done voluntarily. And it's a tremendous amount of work. So I think you all need to give each other and yourselves a round of applause, because it's tremendous work, and we could not move forward in our cancer plan if it wasn't for all of your efforts, and they are so greatly appreciated. And I just wanted to thank you.
Couldn't have said it better, Lynn. And I think that's a great place to be, where we can reflect on what this past year has been, and it's certainly been, even as we're moving into almost 2 years into our current state of pandemic, and how we as a coalition have navigated to be what we are together in a more virtual manner, and even sort of the hopefulness for how we will move forward to really bridge more access, more equity, more strategy to be able to deliver on basically all of the missions that we have here, not only as a coalition, but also into our day jobs, if you will. So I really echo Lynn in your thanking, and really just it's been such a pleasure to even, again, kind of to the front end of this meeting, serve in this capacity. And I look forward to continuing to be a member of this coalition after this role here in this manner. So thank you all for this time today, your continued dedication and commitment to this work, and really just we'll keep it going forward. Lynn, I'll give you the floor for any final comments in closing.
Can I, before Lynn jumps in? This is Monica.
Go ahead, Monica. Sure.
I really, every time we've had like 2 or 3 where committees report out, And I really want to impress upon you guys as subcommittee and work group members. You talked about so many things that can get published on our website. I've been trying to work on communicating with everybody better. You've probably noticed the Friday sort of newsletter that I'm trying to start. But for those things that you reported out, those are things that we can share online. Those are things that can also, as a heads up, we'll be collecting success stories primarily around health equity. So we can really push at the national level what Pennsylvania is doing. I really encourage you when you see those emails come out and tell you that here's where you can do your success story, that some of those things you kind of input. I just wanted to remind you to communicate with me and let me know, let your DOH liaisons know so that we can get those things up and published. Thank you.
Monica, thank you so much. And for anyone that has not worked closely with Monica, she is a joy to work with. She really is motivated and does a great job. So take her at her word. If she wants the information, send it to her. She'll get it out there. Again, I don't have much else to say except thanks again, everybody. And it's just a privilege to work with everybody. And, I think back on years ago when this was just getting off the ground and how far we've come. Becky, you're shaking your head. I mean, you were there. It's just amazing. Thank you.
Yeah, can I just say thanks to everyone? One of our former co-chairs, Alice Yoder, used to always say, we can do so much more as a group, as a coalition, than we can do individually. And I think just hearing the report outs today is a really good example of that a lot of great work being done because of people coming from around the state and working on something together. So thanks everyone for your commitment and passion and helping us to work on cancer. I really appreciate it.
Thank you, Becky. And we look forward to Casey in your new role and Brenda in your new role. So really just a great amount of information being shared today. And we look forward to how we do all this together moving forward. And we always like giving the gift of time back. So us ending a little early is, I think, on all of our schedules, a little welcome treat. So thank you. And I think, Monica, this can conclude our meeting today.
All right. Thanks, everyone. Have a great afternoon.
You too. Thanks. Bye.
Bye.